Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today we hear from exercise physiologist Katie Stewart and senior physiotherapist Professor Edgar with their latest findings from their research into long COVID. This is the second of a two-part series.
I've now in a bit of a community of practice across Australia, and there's a real debate as to how we should set up our model of care around long COVID. We know that there's lots of variation in what people are presenting with, but we don't understand the demand, so we don't know how many people are coming through. We don't understand what necessarily they need for treatment, and the model of care in the various states is changing. So South Australia's closed their COVID clinics. Western Australia has COVID clinics, but they're in debate at the moment.
There's two?
Yeah, there's two COVID clinics in Western Australia. Yep. Tasmania's got one, and they basically are still persisting with theirs. New South Wales have closed theirs. Queensland's got one or two that are still existing, but basically they're going to close them. And the reason for that is because it's very difficult to set up services that will actually treat people with all of the different varied types of conditions that they might have, but also by the time people were getting to the COVID clinics, they had actually resolved their symptoms because they sat on the wait list for 8 months.
And the varied pathophysiology of it all, in the sense of, as we were discussing earlier, it affects fatigue, it affects cardiorespiratory, it affects nervous system, organs directly and organ tissue. So the ramifications and the spectrum of potential on referral are huge. But the testing to get to that point, that's where those resolution aspects lie, in the sense of 10 months, okay.
Yep.
So, almost 95% resolve within one calendar year, and that's what all the latest research is indicating is continuing to happen. But it is now trickled down into the sub-comorbidity areas of heart, respiratory, chronic fatigue, ME, CFS.
Yep. So the subspecialties are picking up those patients who essentially have ongoing problems in specific organs or disease states, and that's really the only way that the model of care can work at the moment. Even though it is potentially precipitated by COVID, we really have to treat patients based on their presentation, and then the investigations that go with those presentations to identify what we can treat.
Exactly, and in our conversation earlier we had been discussing, so because for you, you're hospital-based, for us we're community-based, primary healthcare, so we see that trickle down back to primary healthcare and the GPs navigating that. There's a few cardiologists who are involved heavily in that process from a specialist point of view, now that those cases have been determined and being able to be diagnosed with secondary conditions or associated conditions or exacerbated conditions. And the difference between the community-based in the primary healthcare is, as I said, our female clients are the ones that are presenting most predominantly in that 45 to 60 cohort, with fatigue, hormone-related, endocrine-related, shortness of breath, persistence, and cognitive dysfunction. And the correlations between those and menopause and perimenopause are really strong. And all those little lines, they sort of thread back through from an endocrine point of view, much like the ME and CFS, and then you find out from a neuro for cardiac or tissue damage, the myocarditis or the pericarditis, whatever it is, which was a bit more of a youthful presentation, wasn't it?
And I think that's part of the reason that it's so difficult to set up a service to actually treat long COVID. They've almost, essentially the rhetoric across Australia is that we probably can't set it up because the critical mass of people isn't really there. But the critical mass of people that you can treat is in the specific organ issues or diagnostic issues. So that's where it makes sense that primary care starts to be the lead for long COVID treatment.
And management ultimately,
Yeah.
because we don't have a formal treatment approach, do we?
No, well, that's right. There's no such
that
thing. There's no such thing as a formal treatment for long COVID anyway. It's really treat the symptoms, treat the diagnose, treat what you can identify.
Yeah, and I think for us as allied health providers, you as a primary researcher and physiotherapist, and me as an exercise physiologist, I think one of the things about long COVID is it is bringing those allied health skill sets together to be useful in that primary healthcare setting, led by the research. But I think, as we said earlier, the numbers of 650 million globally diagnosed with SARS, 56 million?
65, I think. So about 11% of people seem to have been diagnosed or considered to have long COVID.
Yeah.
But that's across all different variants, all different strains. So it's very difficult to understand where we're at the moment.
And the specificities, and most of that recent research around March this year has been around that 4 to 5%
Yep.
in the variant cohorts.
Yep.
So it's interesting to see that pull apart, isn't it?
It's really interesting because there's government papers that we're waiting for in terms of what does the federal government consider is going to be the model of care or the way that we should manage long COVID, and that we're waiting for that to come out. Of course, it was supposed to come out a while ago, but I think that there's a lot of other things going on. But it's really interesting to see the modelling of demand is very, very different across the different states. What we would expect is that 4 to 5% is probably the number of people who are coming through with long COVID after the more recent strains of COVID. But certainly the modelling in New South Wales is way lower than that. They've considered that it's down less than 1%.
Yeah.
In terms of people that you need to treat associated with having a COVID infection and then having long-term symptoms.
And if you compare that to Victoria, who had the highest level of exposure and variant exposure, considering the other states, the perception and treatment approach from a healthcare state health point of view, it's interesting to see the different responses of each of those. But I feel as if we'll be in a similar boat by the time we get to the end of the wait list, or by the time the guidelines are there, it'll have trickled down into that primary healthcare chronic disease management space and will be defined as a comorbidity to identifiable
and I guess
pre-existing condition or associated triggered condition.
And the terminology is already changing. It's becoming a post-viral syndrome, symptoms of a post-viral syndrome. And I guess that, when you extrapolate that outside of the metro area, for instance, it means that I guess people outside the metro area will be able to access some forms of diagnostics and treatment that are similar to the metro area, but I guess it's still going to be a challenge for them to access the more specialised investigations, etc., which would allow them to get the treatment that they need, because not everything can be done on telehealth.
Yeah. I think that's where there's been a really good application of PROMs, so multi-dimensional fatigue index, shortness of breath, perceived health, and even a MEN-OD or a MEN-QOL, just from an endocrine point of view, to reflect those inflammatory responses, general and global inflammatory responses. Because normally by the time we get to address those in a community setting, they've exhausted specialist respiratory testing, respiratory function investigations, cardiac investigations, and the GP has navigated all of those well, and then they're left with the residual symptomology of fatigue, persistent shortness of breath, and then as exercise physiologists and physiotherapists, your role then is to intervene and slowly pull apart what pathophysiology is the primary underlying contributor, and then devise a treatment approach from there.
Which is still not clear either when you think about the work of, say, Dave Petrino over in New York. those guys have identified autonomic dystonia in probably about 2% of their population over there, and they've become sort of world experts in that space. And I think that they've been cautioning for a long time as to how hard we can go with exercise training. And I don't think we've sort of got to the bottom of that yet, even though. And I don't even know that we've got to the bottom of being able to diagnose that group. And it's not everyone. So exercise training during long COVID or associated with long COVID is a challenge. And, being able to identify and screen out the patients with cardiac issues, POTS, MECFS, and things like autonomic dystonia, so that there's more specialised treatment for those patients, which is quite different in terms of the exercise prescription compared to, I guess, what would be the impact of an inflammatory process, fatigue, potentially muscle encephalopathies or encephalitis.
Yep.
Muscle.
All those hormone-induced sarcopenic responses, which we've found in that cohort have been co-contributors as well.
So
muscle mass.
They respond to, I guess, normal exercise prescription in inverted commas. We have an understanding, let's put it that way, of how we can treat those patients. Whereas there's a group of patients that I think that really the jury's still out as to how we treat them best.
I think there's a really good, for our listeners, there's a really good Nature review, microbiology piece, and we'll put the details of this up, but it releases a summary of candidate treatments and supportive evidence that just gives a really clear symptom and or biological mechanism, treatment, supporting evidence and commentary around those presentation and treatment areas, which interestingly aligns with the approach that we've had in the community to initially stay away from cardiovascular interventions for all presentations and sit in redeveloping and building lean muscle tissue as a primary and going from there, obviously with consideration of the post-exercise malaise cohorts and POTS, which need on referral and specialist considerations. But with regards to global inflammatory areas, non-tissue or organ impacted, they're the things that we find have been, in fact, in the cases we've had, I don't think there's been one incomplete, but all the completes that have gone through a 12-week recovery program have resolved in full, within that time frame, which by the time they get to us, it is about 9 months. They've done 3 to 6 months of investigating, 9 months, so it makes us look good. But the timing is really interesting and important in that, we're 3 to 6 months of investigative processes, which is our old healthcare model of siloed tracking, and it brings forward another argument for that value-based healthcare response, collectively to make the most of those timeframes. And I love, Dale's had the opposite response in a hospital setting. So what's been your findings and outcomes with regards to treatment approach?
Yeah, so we, I guess, have been exposed to patients who have required admission and ICU admission critical care. And then we've also got the other end of the spectrum where we've got the patients who essentially were managed as outpatients, come into COVID clinic, get identified as being COVID positive, and then get managed at home or be managed at home, isolate and manage at home. So in our study, which actually looks at the wild type Wuhan strain, we're sort of struggling now to get this published because it's pretty old news. But the interesting thing about it, I guess, is that we demonstrated that even at 12 months after having COVID in the first wave, the initial wave, there's still 25% of patients, 25% of patients who actually have reportable fatigue. And that compared to a group who had community diagnosed virus or community viruses, and they had about 1 in 5. So 1 in 4 versus 1 in 5. at 12 months are still reporting fatigue, muscle aches, and shortness of breath.
And the WA cohort, though, from a research point of view, is a very interesting cohort, because I think even globally, I know we were nationally the most highly vaccinated cohort, and isolated, which was,
Yeah, we have a very novel situation in terms of research, because one, we had a population who were unvaccinated when they first got COVID. And so the responses that we see, the systemic inflammatory response, which is why I get involved, because I work in burns, and we know all about systemic inflammatory response in burn care, and it's also why I'm interested as a physio in the exercise component that comes with the systemic inflammatory response and the fallout from that. But what we saw in relation to COVID exposure was a very so certainly some parallels, not exactly similar, but certainly some parallels in the systemic inflammatory response, the immune response, compared to what we see in burns patients. And what we've been able to demonstrate over a long period of time is that burns patients actually have a profile, a long-term profile, which demonstrates that in any organ system that we look at, and various diagnoses such as diabetes, cancer, there's an increased incidence of those diseases of aging, and there's an increased incidence of organ system dysfunction. And not only is that increased incidence compared to someone who hasn't had a burn, we also notice that when someone gets a condition, that there's an onset of a condition, then they end up in hospital about twice as long. So that's the byproduct of a systemic inflammatory response. And I think that's where we see the parallels in COVID, and where we've become involved in COVID research and working with the people, the guys at the Australian National Phenome Centre. We've become embroiled in looking at phenomic profiling and understanding what it is that the immune system does when it gets challenged by these infections that we're naive to, and in the burn situation that we're susceptible to, because there's obviously damage to our barrier system, which prevents us from, or that should prevent us from getting infections.
Yeah, and the severity, are there any correlations between the severity of the burn what's the grading of the severity of burn that correlates with the long COVID or post-COVID syndrome immune response?
We haven't. Well, I haven't. I should say I haven't. There's others in the team that are cleverer than I, and they will be probably looking at where the scale it sits. So what we see in a burn is that no matter how big that burn is, there is a change in the the long-term immune profile of patients. That changes in a dose response to the size of burn. So we have, we're looking at those two different parameters which change, but we know that there's, even with a small burn, there's a systemic inflammatory response. And one of the really nice pieces of work that was done by one of the registrars named Emily O'Halloran, she showed that even in a minor burn, so less than 15% burn, there were measurable cardiac changes in young males after they've had a burn. So by ultrasound, actually seeing tissue changes.
The immune correlations between that, and if you look at the most common symptoms that are presenting in the community of that persistent fatigue and shortness of breath with long COVID, those immune correlations, I can't recall, I'll find the research piece and we'll put it up on the list as well, but I recall that there was a piece of research looking at the long-term immune and correlating chronic disease health impact over the next decade, trying to extrapolate between diabetes, obesity, respiratory dysfunction and cardiac, which are our top chronic disease contributors to healthcare costs and social burdens. And how does long COVID contribute to exacerbating that? And with, don't quote me, but it was almost as if it was bringing it back 10 years. So those that were going to be suffering from those conditions, if they had suffered from long COVID, they would then be more probably suffering from those 10 years earlier.
Yep.
Or looking to have, as a healthcare system, we would be looking to have to deal with that load a decade earlier.
Yeah.
So,
and I've heard similar sorts of numbers in discussions around systemic inflammatory syndromes and what actually happens with advancing the diseases of aging. Essentially, that's essentially what we believe is happening when you have your body is it has challenged by a systemic inflammatory activity like COVID, like burns.
Yeah.
And I guess if there are, what we've seen is early parallels in what happened with the profiles, the inflammatory profiles, the chemical profiles of patients who had COVID. We've seen similarities with what we've seen in burns, and I guess we've been studying this phenomenon in burns for 15 years. 20 years perhaps. I've been around a fair while now with working with Fiona Wood, and that's exactly what we're seeing, is that we've started to unmask those the phenomenon that are happening in patients long after they have that systemic inflammatory challenge.
So it will be very interesting to see then, there are greater correlations from a chronic disease space in that long COVID. So in a community setting, and I can only speak to our real world findings and outcomes that we've had from our presentation of local cohorts. And some of those are remote and regional, and really importantly, speaking to our remote and regional communities, the ability to have access to virtual servicing is really important, and having, now that it is at the allied health level, it may be more accessible for them to be able to manage that, and obviously we'll be able to leave some information about how they can access those services. But the correlation between lean muscle mass and the critical cytokine and internal biochemistry around immune response is starting to become a high correlation space.
Well established, I think.
Between particularly Rob Newton or Rob and ECU, the great work on oncology, prostate space, and now down to the specificities of dosing and the different types of eccentric, concentric, different muscle contractions to stimulate different responses. So if you look at that, we may have to catch up offline for some interesting work around burns and how lean muscle tissue, with the impact it has, looking at that global inflammatory response for long COVID, that for us in the communities been the most successful treatment application. Just slow increments in lean muscle tissue have generated the greatest response and improved fatigue and shortness of breath, which reflects systemic improvements and reductions in inflammatory elements.
I guess it's interesting just to pause there and reflect on the fact that we haven't mentioned one of the biggest challenges to our community, which is mental health. And one of the things that we saw in our study of obviously the first wave was that the mental health, we're talking about a group of patients who had COVID and a group of comparison participants in our study that didn't have COVID. And what was interesting to us is that there was no difference over 12 months of anxiety and depression symptoms. At 3 different time points in that 12 months, we collected that information.
I think you and I discussed this because at the time, when you and I first met and had our first conversation around this topic, long COVID, COVID at the time and COVID treatment interventions, was in 2022, around April 2022. And at that time, there were indicators and research that was saying that around about 6 months' time, for all of those reasons that people weren't able to access treatment, receiving treatment, that depression symptoms were exacerbating at the 6-month point. And that was that 6-month to 9-month window, that if there wasn't a key intervention point at that time, if there was an underlying risk of mental illness or severe depression, then that was where that opportunity sadly would open, and the symptoms would be exacerbated.
Yeah, well, the interesting thing is, I guess, the back end of all of that. So we demonstrated essentially not a lot of difference. We demonstrated that there was higher levels of anxiety in the community than perhaps what would be the community level of anxiety, whatever that may be nowadays, because I think that the old numbers are probably thrown out, particularly in Western Australia, where it didn't matter if you had COVID or not, the threat of having COVID was actually the impactful event. And that's what we saw in our PTSD survey, our PTSD symptoms survey. That indicated that over the 12 months that patients who had COVID actually had a higher stress level and long-term stress level compared to those in the community who didn't get COVID. But what we saw when we measured anxiety and depression across the whole 12 months is that there wasn't that much difference between the community and the COVID positives.
As a collective in the form of a DAS, or was that an SF36? Or
HADS. Yeah, Hospital Anxiety and Depression Scale. Yeah.
There we go. So, and that hospital is a defining differentiation as well, because it's a heightened indicator PROM, isn't it?
Yeah.
So that again, we're looking at those different variabilities of the condition, community-based stresses, as opposed to hospital presentation-based stresses and experiences, and then how do we trickle those, slowly get them down and filtering down into a manageable space.
Well, I think one of the things that is perhaps giving us hope is that the connection between exercise and mental health, or positive impact on mood and mental health, is also something that we can hopefully progress. Not only when we're looking at the physical symptoms, but we can also hope to get positive responses in terms of the mental health symptoms as well, by using exercise as a intervention.
Which comes back to dosage requirements and the specificities of prescription being really key as part of that. And those considerations are really interesting, because when you look at the contraindications for a long COVID presentation with that chronic fatigue and inflammatory, well, not chronic fatigue, persistent fatigue symptoms as opposed to chronic fatigue, that's exactly the space that they're looking at with regards to mental health implications.
Yep.
But the best treatment for mental health is in those higher intensity interval type approaches. And so you, as a clinician, it's very important that you know what the primary, secondary and tertiary treatment approach should be, and what is the priority for a short period of time, and when is the time to step into the considerations of that secondary, and how do we treat that secondary.
The only way that this can really be managed is what's happening on the ground, what's happening at the community interface. We can't expect, perhaps even in the next 5 to 10 years, that we'll have some masterful test that will say that this is where this person is on the inflammatory spectrum after this disease. I just don't think we'll get there. And in reality, that's an academic exercise, and what is it actually going to do for you if you're a GP and you order a test? Okay, is this person recovered?
Setting,
So I can see that is important for us to perhaps consider how we identify people who are or predict, I'd say, who's going to have long COVID or whatever syndrome it is in the future from another infectious organism. It will be important for us to set up timely models of care, timely care systems for people in the future. I don't think we're going to have it for this bout.
Agreed.
Because what we have at the moment is we've just got to manage what we manage, and that's obviously managing long COVID and the symptoms of long COVID in the community, at the community interface with primary health, driving that ship. But perhaps in 5 to 10 years' time, we're going to have an ability to identify what it is that will predict who is going to have a poor outcome, or have a poor outcome in certain organ systems.
So those people can be prioritised.
So those people can be identified early, driven into streams of early intervention, and hopefully have a much more timely recovery associated with more personalised medicine, essentially.
Yep.
So that's what all this big data stuff is. I mean, I'm really intrigued by it. It blows my mind, I think, but I'm really intrigued by it because I think that that's where we're going. Individualised medicine is what we're talking about. And in the context of COVID, or something like it that causes a systemic inflammatory process, then that's essentially what they're looking for. They're looking for a profile to say, yes, you're X amount recovered, or they're looking for a profile to identify what is going to be your long-term problem.
And that's the difference between that precision medicine from a specialist or community-based level, or from a bigger healthcare modelling lens, where you're looking at identifying vulnerable cohorts, putting them in situations of priority care, and understanding the cost implications from a healthcare point of view of that demographic. And that sort of puts you more back into an ethics space. And how do you look at those spaces?
It also drives value-based healthcare, right?
Yeah.
It's actually trying to intervene early to prevent long-term costs, so that there is more capacity in the system to treat those who need to be treated. You know, we're very fortunate in Western Australia to have, you know, a system that, you know, as much as everyone's, you know, there's a lot of political talk about our system, but ultimately we had a system that wasn't overwhelmed by COVID. We've now got a system that I don't think is quite set up right, based on what we know, but we have a system that can cope with people who get identified as having longer term problems. We're still grappling with the idea of how we manage long-term problems without just continually increasing our focus on acute care and big hospitals and those sorts of things. And I think that that's going to be, you know, our challenge over the next 20 years as to how do we actually set up our systems to identify people early and prevent the long-term and significant costs that come downstream if we don't.
And I think that's probably a really point to close on, in the sense that COVID in many ways, and long COVID as a result, has given us an opportunity in healthcare to observe the complexities and look at things with a different level of urgency and through different lenses, has driven the real world evidence space, has supported value-based healthcare, which continues to move forward into our disrupted healthcare environment. And it's also shed a light on the priorities and research importance in the hospital setting around thinking outside the square of how do we complement and start to lean into that precision medicine, and which is much more pertinent in that hospital critical triaging setting.